for me. This is our third Thyroid Awareness Month session that we've done. We started 3 years ago, and we didn't want to give up on it this year just because we were going to be virtual. So I really want to thank Jeff for all of his efforts to pull this together for all of us. And of course, for Dr. Sam Tam, who is joining us to explain the surgical component of the thyroid. So just to get going, we're going to start with thyroid anatomy. So when we're looking at the thyroid is a butterfly gland. We have a right lobe, a left lobe, and an interconnecting tissue, and it is right above the trachea. And I'm so sorry, excuse me. And it's right above the trachea. Okay. One of the things that I always tell my patients is that I would like for them to do their own thyroid neck checks, which can be performed at home. You want to tip your head just like the cartoon is showing. You can hold a mirror up to look at your neck, and then you drink some water. And what you're going to see is right between the two bones here is where the thyroid falls. And you can watch carefully as it kind of comes up and down as you swallow. Okay, so we're going to start with an underactive thyroid, which the medical term is hypothyroidism. So hypothyroidism is the underactivity of the thyroid gland. And this is when the thyroid does not produce sufficient amount of thyroid hormone for the body's requirements. You notice that most of the body kind of slows down. Sometimes it's temporary, and I will talk about that. That occurs when you have thyroiditis. And there's 25 million people who suffer from thyroid disease, and many people are not diagnosed. They're just walking around, probably not feeling at their best. So what are some of the symptoms? In the early stages, probably very few. Additionally, the body can compensate for it. And what we see is we see in our clinics an enlargement of the thyroid, or we call goiter. Goiter means the normal enlargement of the thyroid gland. But as the thyroid hormone production decreases, body's metabolism slows down, and many people can become symptomatic. The symptoms overlap with many other conditions and tend to be non-specific, but these are the general ones. People complain of being tired. People feel that they're drowsy and forgetful. The children may have difficulty with learning in school. People will notice that their hair is dry and brittle, or their skin is very itchy and dry. You can get, with severe hypothyroidism, you can get puffiness of not only the face, but the entire body. People can have constipation and sore muscles. The weight gain that's seen with hypothyroidism is not per se weight gain due to the thyroid not functioning, but it's due to all the other things we talked about. The fact that people retain water, the fact that people are not as active because they're lethargic and their metabolism slow down a bit. For women of reproductive age, they can have heavy or irregular menstrual flow. And there's a higher risk of miscarriages in our women of reproductive age. So we definitely want to treat thyroid disorders in a pregnancy. And there may be increased sensitivity to many medications. So what are the causes of hypothyroidism? Some of the ones that I see regularly in the clinic is autoimmune thyroiditis. Autoimmune thyroiditis is interesting. It's the body's own immune system it produces like a reaction to the thyroid gland, and your thyroid cells can be affected, sometimes permanently destroyed, sometimes not. And in compensation for that, the thyroid grows to compensate and try to produce more thyroid hormone. Another cause is radioactive iodine treatment. For instance, which I'm going to talk about in the next category, which is overactive thyroid. One of the treatments of an overactive thyroid is radioactive iodine. Now, radioactive iodine is a treatment where you're getting iodine. The only gland in the body to incorporate iodine is the thyroid. It goes into the thyroid cells, and then it melts the thyroid cell, and the patient develops an underactive thyroid. There's also another reason for hypothyroidism, which is subacute thyroiditis. This is also known as painful thyroiditis. This is quite uncomfortable for our patients. We have to put them on steroids to help them with the pain that they feel. They cannot wear turtlenecks or shirts around their neck. The thing that's very interesting, though the patient is quite uncomfortable, recovery of the thyroid is more often than not. So most of the time, this painful thyroiditis is only temporarily causing an underactive thyroid, and people will recover. However, some do develop permanent underactive thyroids. Spontaneous onset, that is, we really don't know. The patient all of a sudden was fine. Now they have an underproduction of thyroid hormone. We don't find any antibodies that are positive in their system, and we need to put them on thyroid hormone. Thyroid surgery obviously will lead to an underactive thyroid. And there's certain medications that are being given for other reasons, like lithium, high doses of iodine. We almost say like high doses of iodine constipates the thyroid so that you develop an underactive thyroid. Amiodarone, which is a heart medication, is loaded in iodine and can cause an underactive thyroid. For our women of reproductive age, we talk about postpartum thyroiditis. After delivery of their baby, they can develop an overactive thyroid initially. That's when they spill all the thyroid hormone into the system. And then their thyroid is too sick to recover. So it's followed by an underactive stage once you clear all the thyroid from the body. And then most of the time, the body will recover and they develop normal function. However, those women who have autoimmune predisposition, that is that their thyroid peroxidase antibodies are positive, are more likely to develop a permanent underactive thyroid. There's also congenital conditions, like infants can be born with an inadequate amount of thyroid tissue or an enzyme deficit, which leads to abnormal thyroid hormone production. In the United States, a thyroid screen is done on every infant that is born because it is extremely bad if these patients are not treated. And if you treat them, they have absolutely a normal life expectancy. So it's one of the newborn screens that all infants in the US are screened for. And pituitary hypothyroidism, actually I had clinics just before this talk and I just saw a young man. This is sometimes due to brain cancer. Patients get radiation or chemotherapy, which affects the pituitary, and the signal to send for thyroid production is affected, and patients develop an underactive thyroid. These people are not followed with traditional labs, which is the TSH labs. These patients with pituitary hypothyroidism are followed by free hormone labs, like a free T4 lab or a total T4 lab. So how do we diagnose hypothyroidism? Well, usually my patients will come in and describe signs of physically being tired and the symptoms that we reviewed earlier. The easiest and the most sensitive test we have is a thyroid stimulating hormone test, which is a simple blood test to evaluate for hypothyroidism. This test we ask our patients to do in the morning and to stop all vitamins containing biotin, which is B7, for about 4 days prior. Not that biotin is bad to take, but it can interfere with the assay. The assay for thyroid and many of the labs are actually biotin based, and it leads to errors in interpretation. So for the best accuracy, we tell our patients to hold off on these vitamins for 4 days prior to the blood draw. In our system, we have a thing called a direct TSH. That is, if the thyroid comes back abnormal by TSH, automatically there's a reflex-free T4, which is the active thyroid hormone in the blood. And we may, depending on the individual, check for autoantibodies like the thyroid peroxidase antibodies to see if they have the predisposition for Hashimoto's thyroiditis, which is one of the most common reasons of autoimmune hypothyroidism. So what are the treatments of hypothyroidism? Usually it's a very simple single dose of T4, or we say levothyroxine tablet. It is a little bit of a tricky pill to take. We tell our patients to take it first thing in the morning on an empty stomach with water alone. Wait 30 minutes to eat or drink or take other medications, and all vitamins, specifically calcium, iron, which can bind the thyroid and interfere with absorption, we ask to take 4 hours later around lunch or dinner time. It may take months for patients to notice an improvement in their symptoms once thyroid hormone is placed. It is not a quick fix, which can be frustrating to the patient, but the good thing is that they are in the correct treatment and that over time they will notice an improvement. For our older population, we actually start with very low doses. Part of the reason is the heart has receptors for thyroid hormone. We do not want to oversaturate those receptors, which can lead to irregular heart rhythms or congestive heart failure. So we go ahead and do it in slow dose increments so that the heart is not overwhelmed. And this condition, if you have autoimmune thyroid disorders or some of the other causes that we discussed earlier, is usually going to be given for an entire lifetime. We monitor our patients annually by the blood test, though some of my patients may have a little bit more difficulty getting to goal, and we will monitor them as frequently as we need to make sure that the patient has appropriate thyroid levels. Our tablets for traditional synthetic thyroid hormone comes in greater than 10 different strengths. And like we mentioned earlier, it is very important that it's taken regularly and consistently. If you take excessive amount of thyroid hormone, you may develop symptoms of stress on the heart, irregular heart rhythms, congestive heart failure, and thinning of the bones. If you take on too little thyroid hormone, the thyroid goiter can grow to try to, again, compensate. But we also know that as far as cholesterol, the LDL receptors, LDL is the bad cholesterol in our body, requires T4 for the receptors to grab it. They're located in the liver and dispose of it. So for patients who have an underactive thyroid, we need to treat them properly so their cholesterol levels stay normal. If treated improperly and the dose is too low, cholesterol levels can go up. And as we know, cholesterol is associated with heart disease. A word about women of reproductive age. If a woman is interested in pregnancy and they have an underlying thyroid disorder, we have strict recommendations that prior to conception, the TSH, which is the most sensitive test that we have, be below 2.5, and that we check that regularly. Once the woman is pregnant, we usually increase her dose of thyroid hormone by 30%. Women who do not have thyroid disorders naturally produce 30% more thyroid hormone for their fetus. And a woman who has an underactive thyroid, not only is she not able to make thyroid hormone for herself, but she would not be able to muster up the 30% needed for the infant. So we monitor, check the labs, and see if the 30% increase is required. It is very important that our women of reproductive age seek medical treatment prior to conception so that labs are good at conception. And once they're pregnant, reach out to us so that we check the labs early in the first trimester. Thyroid hormone is critical for normal brain development, and we do not want to miss the opportunity to treat when it is such a simple thing to do. Okay. So my next topic is going to be the overactive thyroid. Okay. So the overactive thyroid, meaning there is too much thyroid hormone, every function of the body tends to speed up. So our patients will complain of feeling very nervous. They feel irritable. They have increased perspiration. Their heart is racing and they can feel palpitations. On exam, we notice that the patients can have a mild tremor. They may have difficulty sleeping. They're noticing thinning of the skin, fine brittle hair, and unintentional weight loss, despite the interesting fact that they're very hungry and have a good appetite. For women of reproductive age, menstrual flow may lighten and menstrual periods may occur less frequently. Graves' hyperthyroidism is one of the most common reasons for an overactive thyroid. It is an autoimmune disorder that passes in families. Eyes may look enlarged because the eyelids are elevated. I'm going to show you a picture of a woman with Graves' orbitopathy, or what we call Graves' eye disease. It could affect one or can affect both eyes, and many individuals will have a goiter from the Graves'. It usually doesn't have nodules. We call it a diffuse goiter in the fact that it is pretty smooth and pretty large. This is an example of a woman with Graves' eye disease. And what you could see is that you could see the white on the top of her eyes. That should not be present because the eyelid should be low enough to cover that. But because of what we call the lid retraction, or the eyelid goes back, we see the white of the eye and the individual looks as if they're staring at you. This is classic presentation of Graves' eye disease. There's other forms of overactivity of the thyroid that are not related to autoimmune disorders. One of them is toxic nodular goiter. These are individuals who don't have a smooth thyroid, but they have a lumpy, bumpy gland with multiple nodules that can grow over time, and their activity or their output of thyroid hormone increases to more than normal. And it could be multiple reasons why this happened. It can, there's also familial origin for this. So we will see patients who have told us that their family members have undergone surgery for an enlarged goiter, and that they are now presenting to our clinic with an enlarged goiter with multiple nodules. Another reason thyroid can become overactive is the thyroiditis. That's that system where you're either a viral infection or something hits the thyroid. The individual spills all their thyroid hormone into the bloodstream, and the individual has an overactive symptoms. When the thyroid hormones leak into the system, they're eventually cleared by the liver, and there may be an episode of an underactive thyroid following it until the thyroid recovers. The traditional thing is that the thyroid will recover. Some people's thyroids never recover, and they are permanently underactive or hypothyroid. The diagnosis of an overactive thyroid starts with a physical exam. What we will notice is that their thyroid is enlarged. We will check vital signs and we will see that they have a rapid pulse, that their hands are tremulous, the reflexes are fast, and they have these bulging eyes. We do laboratory testing. Again, the thyroid TSH is one of the best, which would be undetectable. So it is the opposite of what we think. TSH goes up with an underactive thyroid, saying that it's a signal to produce more, and TSH becomes undetectable with an overactive thyroid, indicating there's way too much thyroid hormone in the system. I'm shutting down all signals to produce more. One of the testing that we can do to diagnose an overactive thyroid is done in nuclear medicine. It is called a thyroid uptake and scan. And the scan will find out if your entire thyroid is overactive or if you just have one nodule that is overactive. And these are simple pictures of what I get from nuclear medicine. You can see in panel A, people with normal thyroid function. You could see a little bit of black dots there, not too bright, but looking pretty normal. In panel B, this is what Graves' disease looks like. You have uptake in both lobes. We said it's a butterfly gland, the right and the left, and it is pretty extensive throughout. In people who have multiple nodules that are overactive, that would be panel C, which we call a toxic nodular goiter, and it has multiple spots that are hot. And panel B shows one big nodule that is producing excessive amount of thyroid hormone, and that is in a toxic adenoma. So what are the treatments for an overactive thyroid? One is anti-thyroid drugs, which the most common anti-thyroid drugs we use is PTU or methimazole. 2, radioactive iodine. And 3 is surgery, which Dr. Tam will talk about in a minute. So we are past the lecture part, and now we're going to do the fun game. So Jeff, I don't know if the folks have logged in already to that.
Yep. So if you all have downloaded the Kahoot app, it's a link again was in that email. It's just a little purple square on your phone there. Go ahead and click that. Towards the bottom, you'll see where it says enter PIN. So it's got a little square down there with the yellow box, red box, blue, and green. It says enter PIN. Go ahead and click that. And then you're just going to type in the number that you see on screen here. So 2512914.
And you don't feel compelled to put your real name. You could put initials. You could put something funny.
Yep. So you can give yourself a nickname, anything you'd like. So we'll give everybody a minute to join for anybody who would like to take part in this. And then we'll kick it off here shortly. And we do have the chat function on Zoom. So if you're trying to join but having trouble, need a second, just let us know and we can hold before we kick it off. We've got one person working on joining here, so we're going to hang tight for just a sec.
No problem. No problem. And for those at home who don't want to do this, just do it at home. It's just for fun.
All right, Dr. Levy, I think we are good.
Okay. So we're going to start. Okay. All right, here's the first question. What are the causes of hyperthyroidism? You have 15 seconds. Graves' disease, toxic nodular goiter, thyroiditis, or all of the above? Okay, very good. You guys did great on that one. The answer is Graves' disease is correct for the one person who did it, but also thyroiditis and toxic nodular goiter are causes. Okay, we're gonna go next. Okay. Oh, and it gives you a little score. Okay. Which of the following is not a symptom of hypothyroidism? 28 seconds. Fatigue, constipation, tremor, dry, brittle hair. Oh, wow, you guys are really good. Wonderful, wonderful. Okay, so that is correct, tremor. Fatigue, constipation, and dry, brittle hair are not necessary. Those are all hypothyroid symptoms. A tremor indicates excessive amount of thyroid hormone, and so that would be associated with overactive or hyperthyroidism. Okay. All right, next. How is hyperthyroidism treated? Surgery, radioactive iodine, antithyroid drugs, or all of the above? Very good. Okay. So it is both surgery, all surgery, antithyroid, and radioactive iodine are all treatment options for an overactive thyroid. Very good. Next. Okay. I think we have one more. This is a true or false. It is important to keep thyroid levels tightly controlled in pregnant women. Very good. You guys did great. It is absolutely imperative that thyroid levels are well controlled in our pregnant women. Okay. So I think someone is going to be announced. Steve, whoever you are number 3. L. Clark, number 2. And the winner is RAD. Great job. All right, runners up, 4 and 5 below. So I think we're going to move on to Sam.
Sounds good. Can you hear me?
Yep.
I'm going to share my screen. Oops. Okay. Can you see my slides? Perfect. So I'll talk a little bit about surgery. I'm Samantha Tam. I'm one of the head and neck surgeons. We work very closely with endocrinology in dealing with the thyroid because there are, as you can see, lots of things that you do medically to help the thyroid, maintain its health. And sometimes you need to do, unfortunately, surgery. So I guess the first thing to ask is why surgery? We have this day devoted to thyroid awareness, these diseases that can happen in the thyroid, and Dr. Levy's done a great job about summarizing the reason why the thyroid is so important. So why would you ever want to take it out? And the difficult thing is that there are some situations that you end up needing to take it out. Like we were talking about at the very end, if you have a very overactive thyroid and maybe the medications aren't working, maybe the radioactive iodine isn't working, the most definitive way to get rid of that extra thyroid hormone that's being produced would be to take it out. And so there are other reasons that we have to take out the thyroid gland. So for example, if you have a nodule on your thyroid, we're not too sure whether or not it's cancer or not. In order to figure out, we have to take out the entire thyroid so we can look at it under the microscope. So that's the most common reason. Other common reasons are thyroid cancer. We talked about hyperthyroidism. So if you have an overactive thyroid, We aren't able to control it in other ways. We can take it out. If you have what's called an enlarged goiter, so this is basically an enlarged thyroid gland that can cause some compression in the surrounding areas, causing symptoms, or maybe cosmetically, cosmetically you can have a larger neck in that area. You might want to take out a thyroid for that. Other reasons, there are lots of other kind of weird and wonderful reasons that you may have to take out a thyroid if you have cancer in the surrounding areas that it's affecting that, or if, for example, your parathyroid gland can be in the thyroid, those types of things. So I guess the first thing I want to talk about is this, us taking out these thyroid glands for thyroid nodules. And the interesting thing about our role as surgeons in this is that even though, you know, I was trained and love to do surgery, that's why I'm in the career that I have, we've really noticed that because we're getting more CT scans, ultrasounds, MRIs for different reasons, we're actually catching a lot more of these tiny little nodules that you might not have caught at all in anybody's lifetime before then. So when we looked at our numbers for thyroid nodules and thyroid cancers, we found that, you know, there was an increase in those numbers with these imaging technologies being used more frequently, but we weren't necessarily making any difference for those patients. So one thing that's really changed in managing thyroid nodules and thyroid cancer is we've been trying to figure out ways for us to do less surgery actually in the thyroid. And so ways that we've been doing that is utilizing things like ultrasound criteria to figure out whether or not a nodule needs to get biopsied or not. So even if you have a nodule in your thyroid, it doesn't necessarily reflexively mean that we need to biopsy. We look at the characteristics on ultrasound. We look at how big it is, what it looks like, you know, if it's grown over the last ultrasound or not, to figure out, you know, is this something that we should actually pursue with a biopsy? And once we get a biopsy, we have great technology now for molecular testing. If it's in this in-between stage, we don't know if it's cancer, we don't know if it's completely benign, that we can do molecular testing, send it off, and give us a little bit of a better idea of exactly what's going on. And with all this kind of efforts, we're hoping that, you know, this pie chart will eventually change with time. And so these unknown nodules that we're taking out of the thyroid through taking out with a thyroid with surgery will decrease, and, you know, we'll have more of these patients that are getting treated for, you know, reasons like cancer, hyperthyroidism, and enlarged goiter, and a smaller amount that we're treating for these nodules that we just need to figure out if they're cancer or not. So that's kind of the general trend about where surgery is going. And I think it's kind of interesting because as a surgeon, you don't really think about not wanting to do surgery, but definitely in the thyroid, we appreciate the collaboration with endocrinology so we can try to do the surgery in the right person. So just say you're talking to your endocrinologist, they're telling you, you know, I think that we have to really consider doing surgery on the thyroid at this point in time. What should you expect when you come and see a surgeon like myself? Well, first of all, we'll bring you into the room and we'll chat. And we'll chat about a whole bunch of things about your entire history. You know, when did things start? When did you start to notice things? But we'll also talk about some of the symptoms. Like, do you have any difficulty swallowing? Are you having difficulty with certain consistencies of food going down? Do you have any difficulty breathing? Have you noticed any problems with your voice? When you feel your neck, are you able to feel your thyroid lump? Has it grown in size? Are you able to feel any other lumps or bumps in the head or neck? And then, depending on the specific situation, if there's a suspicion for thyroid cancer, then we ask about whether or not you have any thyroid cancer that runs in the family, because we know that there are some variants of thyroid cancer that can run in the family, and whether or not you've had any radiation in the head or neck area, any exposure to radiation in that area. And that might be, you know, radiation that you had years ago for lymphoma in that area, or for example, when you're getting radiation from breast cancer, there may be some radiation spread to that area as well. And why are those types of things important? And it has to do with anatomically exactly where the thyroid is sitting. And the thyroid sits in the front of your neck, right here, like a butterfly-shaped gland right here. And this is your Adam's apple here. This is your windpipe right there. And so you can imagine if the thyroid gets very large, the windpipe has these nice rings of cartilage that are nice solid bridges. But if the thyroid gets very, very large, it can push that windpipe one way or another, or can narrow it. And this might cause some difficulty breathing. Usually you can hear a little bit of a wheeze or something like that. And it especially can occur, you know, when you're exerting yourself, like going up a couple of stairs. In terms of the voice, the thyroid can also affect the voice box. And this is because of the voice box sits right in here, just underneath your Adam's apple. And if we take a look at this picture, you have a thyroid, half a thyroid here, and we've cut away half of the thyroid on this side. This is the nerve that comes up and around and into the voice box here. And this nerve helps the voice box move, as you can see in this picture here. And so if, for example, you have any kind of nodule or something that's invading this nerve, then you can lose the function on one side of the voice box, which would lead to what we call vocal fold paralysis, and one side won't be able to contact the other side. You can see like the voice box here comes together really well, gives you a nice strong voice. Well, in a situation where one of the nerves is affected, that other vocal cord can't come over to the side, and you end up with a breathy voice like this. The last thing is for swallowing. Why is it important for swallowing? Well, this is a kind of an aerial view, a cross-sectional view of the neck. Here's the thyroid, one side on this side, one side on the other side. This is the middle part of the thyroid. This is the windpipe. We're looking into it like a tunnel. And then right behind the windpipe is our esophagus. And the thyroid, you can imagine, can grow over here and squish the esophagus one way or another. Unlike the windpipe has these cartilage bridges like I was talking about before. The esophagus is very soft. And so usually when people talk about difficulties with an enlarged thyroid, the swallowing symptoms are there before we have any kind of breathing symptoms. So after we've talked about all your symptoms, then we move forward with an examination, and we'll be examining your thyroid gland as on top of the rest of the head and neck area. The thyroid, I think that one thing to know is that when a lot of the times when we go on the internet and we look for a thyroid examination, a lot of people examine way up here or way up here, but the thyroid really sits low down in the neck, right on top of the breastbone area, right in the middle. And so that's where we'll be feeling and palpating to see whether or not we can feel the thyroid nodule. Sometimes thyroids can be pretty difficult to feel because they can actually fall down underneath the breastbone, which makes it even more difficult to feel. If we have a suspicion of thyroid cancer, we'll be feeling elsewhere in the neck as well. And then the other thing that we do, especially as head and neck surgeons, is we want to take a look at how that voice box is working. Because if we have a high suspicion for something that's affecting the voice box nerve, we want to take a look at that. And on top of that, we also want to take a look at that voice box nerve before we do any surgery, so we can establish whether or not there are any issues before. We can figure out how likely is there going to be an issue after surgery? How might the voice be affected by surgery? In order to do that, we go in through the nose with a special camera, and this is very long, not because we have to go all the way through in, but it's long so that when we get to the place that we need to be, we're not nose to nose with you. It's a little bit uncomfortable, but it's a quick procedure. It lasts approximately 30 seconds. And during that time, we do numb that area. We take a look inside and we ask you to say E, make a couple of sounds, and we're able to assess your vocal cords directly through vision. So then afterwards, after we've kind of talked about, you know, what your symptoms are, and we've examined you, how do we make a decision about surgery? And as a surgeon, we take a whole bunch of things into consideration. What did we find out when we've been talking to you? What have we found out when we've been examining you? For example, what does your vocal cord look like? We rely heavily on our endocrinology colleagues to tell us what their thoughts are in terms of the thyroid. Do we think that there's any kind of suspicion on the other side? Should we take out the full thyroid or half of the thyroid? We take a look at what imaging and biopsies look like your ultrasounds. You may have a CT scan before to get a complete understanding of your entire history. We also think about your general health. So for example, if you're a young 30-year-old patient without any other health issues, that might be different than treating somebody who is 90, 95 years old with a lot of health issues. But one of the biggest things that we care about is what your thoughts are, because it's very important as we venture into or as we discuss something like surgery that you are completely comfortable with it. So a lot of the discussion that goes into this is talking about what your understanding of the disease is, what your understanding is of what's going on, and weighing the risk and benefits with your own values. So it's very, very important for us to speak with you to figure out what your opinions are about undergoing surgery. So what are the risks for surgery? So there are a couple of, well, with any surgery, unfortunately, there are risks that are involved. So one thing to expect afterwards is neck tension and tenderness. We make an incision at the front of the neck. I'm just gonna put my screen down at the front of the neck here, and that will be tender after surgery. You will have some numbness there. But during surgery, the other thing we do is you're lying on your back for a period of time. And in order for us to get the best access, we stretch your neck a little bit like that. And so after surgery, a lot of patients might have a little bit of cramping in the neck area and even in the shoulders area, just because of the position that you're in during surgery. Regardless of whether or not we affect the nerve, there are, I would expect to have some type of voice changes afterwards. Some of it just has to do with the fact that we're working very close to the muscles that are close to the voice box. Some of it has to do with the fact that in order for us to do the surgery, we have to put you completely to sleep, and therefore we have to put a tube to help you breathe, and your voice can be affected from that. That same goes with the swallowing problems. Might not have anything to do with any kind of long-lasting complication with the procedure, but you may have swallowing problems because we're working so close to the throat. We are having to move the throat a little bit. You're going to have soreness in that area, and on top of that, you have the swallowing. You have the breathing tube in the throat too. And I don't know if you can see this last part of the slide, but an irritated windpipe, same thing. We have to put the breathing tube in the throat area. We're working close to the breathing tube, and so we're having to move it back and forth, and that might irritate that area too. These common post-surgery side effects are usually shorter acting, a couple of days, maybe a week or two, and then they'll improve over time. There are less common complications with surgery. One of them is a hematoma, and what that is a collection of blood underneath the skin. Thyroid, it affects so many parts of your body, and so there's a lot of blood vessels that go to the thyroid so that they can make the hormone and also deliver the hormone to all the parts of the body that needs it. And during surgery, we try to stop all the bleeding that we can as possible, but sometimes afterwards, like a tiny little blood vessel may open up later on and then cause a buildup of blood underneath the skin. If it's a small amount of bleeding, that's not a big deal, but if it's a large amount of bleeding, because of the structures that are close by, including the windpipe, it sometimes can be an emergency. So for example, oftentimes patients will come into hospital after they've had a large thyroid taken out or their whole thyroid taken out, just so we can watch you, because we know that the bleeding risk is higher in those 24 hours. You can have decreased parathyroid hormone activity. So the parathyroids are 4 glands that sit behind the thyroid gland. And during thyroid surgery, we look specifically for these glands so we don't take them out. They help us control the calcium levels that are in our blood. The difficulty is that even if we keep those parathyroid glands in, if you look at them funny, if you touch them a little bit funny, they can get quite sensitive. And so, especially those patients that we're taking we're taking an entire thyroid out or the remaining half of the thyroid out, we bring them into the hospital to take a look at your calcium levels afterwards, so we can monitor to make sure that those parathyroids are working well. The last one I have here is called a recurrent laryngeal nerve injury. That recurrent laryngeal nerve is that nerve that we saw back at the beginning that curves up and comes and serves that voice box. And that's kind of what I was talking about before, where you can have injury to one of those recurrent laryngeal nerves. And then what can happen is that that side of the voice box cannot come to close the voice box well. And you go from a voice that's projecting well, like I am right now, to a breathy voice like that. The good news is that these types of injuries are not common. For example, a transient or a temporary recurrent laryngeal nerve injury, the rate of that is about 1% to 13%, depending on which study you're reading. And this means that patients may have a breathy voice like this for a couple of weeks or a couple of months, and then they improve over time. Permanent recurrent laryngeal nerve injury happens from 0% to 3.6% of the time. Sometimes we go into the surgery knowing that we're going to have to injure it, depending on what we see beforehand. In those cases, if you have a permanent recurrent laryngeal nerve injury, there are options afterwards to help your voice by pushing that paralyzed vocal cords towards the middle so that that other vocal cord can touch it. In terms of the calcium, the parathyroid gland issues, transient, so temporary effects for that is between 14 to 60% of patients. And in those patients, what happens is they get a calcium supplementation as well as vitamin D supplementation during that time until their body is able to build it up again. The likelihood of permanent hypoparathyroidism is much less, 0% to 11%. And in these patients, unfortunately, it means lifelong supplementation with calcium or vitamin D in order to make sure that your calcium levels are in a safe level. There are a couple things that we do during the surgery in order to help us decrease the risks as much as possible. One of the big things is utilizing a nerve monitor. And what a nerve monitor allows us to do is it basically alerts us when we're working close to the nerve and can allow us to also confirm that a structure that we see is the nerve and that it's working. So how that works is that we have the breathing tube that gets put in when you're fast asleep. This goes down into your windpipe. The balloon goes up in order for us to deliver the oxygen. And right above the balloon, there are these monitors here, these electrodes here. And that sits right where your vocal cords are. So when your vocal cords, when the nerve is stimulated, the vocal cord moves, and those areas will be able to tell us that the vocal cords are moving. And this then sends a signal through the wire. The wire is connected to this machine, and this machine will beep. We utilize a probe that looks something like this during the time of surgery. So if we see something that looks like the nerve, we can touch it to try to stimulate it to see if that vocal cord is moving, and then we hear a beep on the machine, just like this. So this is a bird's eye view of the vocal folds. We have the tube that's going into the windpipe there. These are the electrodes that are there. Here we have the probe. We're touching the nerve. The nerve gives a signal to the vocal fold. It moves, it comes back here and beeps and tells us that it's working. So this has been very useful for surgeons to make sure that we don't injure the nerve and also to confirm that the nerve is working at the end of the case. And what about scar? So thyroid surgery, one of the difficult things is that the neck area is a difficult area to hide, for example, with clothing. It's a very prominent area there. With thyroid surgery, what we endeavor to do is we put the incision into one of the existing neck creases in patients so that we can try to hide them as much as possible. So these are some scars that are about 3 months out. And so certainly the scar is still maturing at this time. The scar is still changing color. And you kind of get a hint of where the scar is there. But for some reason or another, neck scars seem to heal very, very well and can be relatively invisible, at least to the casual passerby, with time. So how do you choose a surgeon? So there's several things to think about. One is the surgeon volume. So definitely we've seen in studies that surgeons that are doing more thyroid surgery have less complications. So, you know, picking a surgeon that does thyroids on a regular basis is better than a surgeon that does a lot of other types of surgeries more frequently and then just does thyroids, you know, on a rare occasion. You want to ask whether or not they'll be using nerve monitoring. You can ask about what their rate of complications are. You can take a look at how they make their decisions in terms of whether or not we want to go forward with surgery. And one thing that I really enjoy here at Henry Ford is that we definitely employ a multidisciplinary team. So it's not just me that's making the decisions about whether or not to take out the thyroid, but Dr. Levy and her team is also very involved in talking about, you know, which should we remove the thyroid now and how much of the thyroid that we should remove. when you're talking about surgeons just in general, you want to make sure that that you're going with a surgeon that's willing to listen to you and address your concerns, because as a patient, it's really important that you're 100% comfortable when you're going into surgery. And especially with thyroid, I think that the discussion with the patient is a very important part of making decisions about how much surgery we're going to do, when we're going to be doing surgery, if we're going to be doing surgery. So I think that that's especially important in thyroid, when we're talking about thyroid surgery. And then who's on your team? So oftentimes I would say that it's, endocrinologists like Dr. Levy and endocrine surgeons like myself. So that's either a head and neck surgeon or an ENT surgeon or a general surgeon that has special training in endocrinology. If, for example, you have a thyroid cancer, then we may have other physicians involved, like a nuclear medicine physician, which will be doing radioactive iodine, and pathologist that will be looking at the thyroid after it comes out, medical oncology and radiation oncology, depending on whether or not you need any other treatments. And then depending on how your speech and your swallowing are, we may involve our laryngologists, which are specialists in voice and swallowing, and a speech language pathologist, which also are specialists are specially trained as swallowing therapists and voice therapists. In order to coordinate everybody all together, we also give lots of thanks to our nurse navigators and our nurse practitioners that are ensuring that our patients have coordinated care, because you see all these people on your team. It's hard to make sure that you get to see the right ones and we're all talking with each other, etc. So there's a big team that's involved with all of this. And that's all I have for today. Let me know if you have any questions at all.
All right, thanks, Dr. Tam. Thank you, Dr. Levy. So we do have a few questions. Sorry if I'm getting some feedback. Hopefully that helps. Can you hear me better?
Yep.
Okay. So we do have a few questions here. We'll start with the first one. Can you have nodules with hypothyroidism? How are they treated?
Yeah, so absolutely. You can have nodules without, so the person actually is asking an excellent question, because it brings up the point that when we're talking about the thyroid, there is anatomy and then there's function. You can have completely normal function with abnormal anatomy. You can have abnormal function with abnormal anatomy. And so yes, you can have an abnormal function, either overactive or underactive, with thyroid nodularity together.
All right, thanks, Dr. Levy. Moving on to our next question here. If I'm pregnant and have Graves, should I get my levels checked more than once a month?
Okay, very good. So traditionally with our Graves patients, it depends if it's treated Graves in the past, like they got radioactive iodine and now they're on maintenance thyroid hormone. Those folks, we usually check in the first trimester. I check anyway, in the first trimester, a TSI to see if the Graves hormone is present in the bloodstream for the mom. If it is not, rest assured, nothing's going to happen to baby. If it is, we check it again at 24 weeks, the TSI levels, to make sure that if it's there, if it's higher, if it is higher, we speak to our high-risk OB, maternal fetal, and they will get special ultrasounds of the fetal thyroid to make sure that a goiter is not occurring in the baby. As far as thyroid function, if the patient is on underactive thyroid, we follow the same underactive treatments. That is, if it's already treated Graves' disease, they are now on normal thyroid hormone like levothyroxine. We would check it in the first trimester, and approximately I do 2 to 4 weeks in the first trimester, every 2 to 4. Into the second and third trimester, we're able to span it out further, because at this point the baby is fending for themselves, can make thyroid hormone, and they could be monitored less frequently. So just second and the third trimester again. If the patient, however, is Graves' disease on anti-thyroid drugs, we may check it as frequently as every 2 weeks the entire pregnancy if it's difficult to control. Also, many of our women, pregnancy is an interesting state. It actually is a protective state in the fact that many autoimmune conditions quiet down during pregnancy. and then we see a big flare up after delivery. So we may check it regularly in the pregnant state if it's difficult to control. If it's not difficult to control, we can maybe relax it a little bit, but definitely check it also after delivery. So the answer is I don't have an answer directly. It's very individualized for the individual patient, what they're treated with, what is their underlying condition, and what is the risk to their baby.
Thanks, Dr. Levy. If you have a nodule and a biopsy is performed, is that an accurate way to diagnose cancer?
The answer to that is the best way to diagnose cancer is to have Dr. Tam take it out and tell me if there's cancer there, unfortunately. But second best to, and as Dr. Tam alluded in her talk, is we are doing everything in our power not to take out normal thyroids. So nowadays we have molecular markers that we're doing on every biopsy that qualifies. If I do a biopsy and it comes back negative by cytology, and what I mean by cytology is what the cells look like to the pathologist. I grab cells, I put it on a slide, and one of our pathologists is going to look at those cells under a microscope and describe those cells to me. If they look completely normal, that is very reassuring. But am I going to let you go as a patient? Probably not. Once you have a nodule, either myself or a primary care doctor may continue to monitor that nodule if it's yearly ultrasounds or every couple year ultrasounds, depending on the risk of that nodule. If that nodule is a little bit suspicious, but and the cells look a little bit suspicious on what the pathologist sees, we will often send for molecular markers. Molecular markers are very good nowadays because it lets Dr. Tam know what kind of surgery she needs to have. So if some of the ones that we worry about, like if there's some worrisome markers there, which is a molecular genetic test, then Dr. Tam may want to do a little bit more aggressive surgery. And what do I mean by that? Even if the nodule is just on the right, but it has very concerning characteristics that it might be the kind that spreads, she may not just want to do the right lobe, she may want to do the entire lobe, the entire thyroid. So I think that biopsies are excellent. They're very reassuring. Molecular markers are an added protective to that, but often we monitor our patients and periodic ultrasounds, which has no ill effects, no radiation exposure, nothing bad, is an easy way to monitor these nodules over time just to make sure that we are safe.
With autoimmune hypothyroidism, how often should someone be seen by an endocrinologist?
So traditionally we see our patients once a year, but some of our patients are a little bit more difficult. They may have celiac disease in addition to hypothyroidism, which may make them have difficulty absorbing their thyroid pill. They may have bariatric surgery, which can affect our ability to absorb thyroid pill. They may have underlying inflammatory bowel disease, which may affect their thyroid pill absorption. All these folks we're probably going to see maybe yearly, but sometimes, what we do is we actually give them standing labs and we have them check it every 3 to 6 months to make sure that the levels continue to be steadily okay, because there's so many factors and variables with underlying medical conditions in some of our more complicated patients. For a simple, no other medical problems, and we see them for Hashimoto's thyroiditis, once yearly clinical exam along with laboratory evaluation is fine.
Okay. Can you have a partial thyroidectomy and be on no medication?
Dr. Tam.
Yeah, certainly. I think the things that go into that is what are your thyroid levels beforehand? And so there are patients that, for example, you've had some thyroiditis and we didn't even know about it, and you may have borderline lowish thyroid hormone to begin with. If we take out half of that thyroid gland, then definitely you'll likely be on it. There are many reasons why we only take out half the thyroid gland, but one of the major reasons is to see whether or not we can keep the thyroid hormone functioning normally afterwards. And even if we aren't able to keep it functioning completely normal afterwards and you need a little bit of supplementation there, at least you have your normal thyroid gland to help you regulate any kind of changes in thyroid hormone that you have moving forward. So certainly by taking out half of the thyroid gland, we're hoping, we're crossing our fingers in your situation that we wouldn't have to put you on medications. But if we do, then we also have that other thyroid half to help us out.
Thanks, Dr. Tam. Next question, can thyroid levels cause dry eyes?
Can thyroid levels cause dry eyes? Well, if you have an underactive thyroid, we know that you can get dry skin, etc. But interestingly enough, with Graves' disease, the answer is absolutely. It's not so much the levels, it's the autoimmune disease. Our patients have, when they have Graves' orbitopathy, if you speak to we're very fortunate at Henry Ford that we have 2 ophthalmologists that are Graves trained ophthalmologists. So it's a very subspecialty. And the patients we send them are patients like this, that is patients with Graves' disease who complain of significant tearing, but they actually have very, very dry eyes. And our Graves ophthalmologists, both Dr. Christian George and Dr. Swapna Vamori, will treat them often with different kind of either ointments or eye drops if needed.
Thank you. This one might be a little specific, but we'll ask it. So if someone has 2 enlarged goiters that have been tested, TSH tests have been normal, is there a way to reduce the size without surgery?
Okay, so that's a very good question. The question is, if you have more than one thyroid nodule, is taking thyroid, and you have normal thyroid function studies, is taking thyroid hormone from the outside going to shrink the goiter? The answer is most of the time it can, but this has fallen out of favor. So in the 80s, this was a very common practice amongst endocrinologists. That is, let's try to shrink the goiter with taking thyroid hormone from the outside. Unfortunately, what we caused was a lot of people with irregular rhythms, congestive heart failure, and all this excessive thyroid hormone in their body for the sake of shrinking a goiter. So the answer to that is it's fallen out of favor. We're really not practicing that way anymore. If we have a goiter that is causing, it's getting larger and it's actually causing compressive symptoms, that is swallowing difficulty, voice issues, we send you to Dr. Tam for an evaluation. It doesn't have to be cancer. We have sent, I just saw a patient in the clinic the other day. She has a huge goiter and her windpipe is moved all the way to the side and her windpipe is closing. We did a biopsy, everything's negative. This has nothing to do with cancer. It's just growing. And this woman should get that out before it causes problems to her windpipe. So, I think that sometimes, as much as we don't want it, surgery has to be done.
Okay. After a partial thyroidectomy, how often do you need to follow up with your endocrinologist?
So that depends on what the partial thyroidectomy was for. So if it's for cancer, you have to see us. It all depends on what kind of cancer. If it's aggressive, I assume if it's partial thyroidectomy, that's not aggressive cancer, they would have taken the whole thyroid out. Traditionally, those folks can see us once a year. If it's for an underactive thyroid, pretty similar, once a year, as long as the blood work looks normal. Often they may not, if they just had it for like a cyst or like we said, something that is not a cancer that they had part of their lobe removed, they can actually see their primary care doctor. So they're not seeing 5 million specialists with 5 million copays, getting their thyroid labs routinely checked through their regular doctor. And only if the thyroid labs become abnormal, come back to see us so we can advise on what to do next.
Okay. How does hypothyroidism cause inflammation in the body?
Okay, so when we talk about hypothyroidism and inflammation, we're probably thinking about Hashimoto's thyroiditis. This is an autoimmune thyroid disease, the most common reason that we have thyroid disorders. I'm not sure about inflammation of the body, but it does cause multi-system effects. Like we know it increases the risk of miscarriages and otherwise. I know that some of my colleagues who practice functional and holistic medicine speak of the inflammatory component of it. The only real way that we have to treat an underactive thyroid is thyroid hormone, whether it's traditional medicine, synthetic, or some of the compounded medications, which some of our holistic and functional medicine doctors tend to prefer.
Okay, thank you. Are there foods to eat or foods that should be avoided?
That's a common question I get. The answer is if your thyroid is underactive, there really isn't much you're going to do because at this point your factory is gone. You're not going to affect it in any way. Given what I said, that in some of our patients who have nodular goiter, if they're going to eat a bunch of kelp or anything very, very high in iodine, they're going to give a lot of iodine to a factory, which is in that nodule, to produce excessive amount of thyroid hormone. So I would probably just monitor that you're not taking excessive amount of iodine containing foods. Though iodinated salt is fine, traditionally that is never excessive. They talk about this concept of goitrous foods. That has not panned out so much. Traditionally, just following a healthy diet is fine as long as you take your thyroid pill in the morning and you don't take any food for 30 to 40 minutes from your thyroid pill, you should be fine.
Thank you. This one might be a little specific too, but I will ask it. So for a period of time, this individual started experiencing problems coping with heights, so like climbing hills, going upstairs. But once a provider increased dosage, the problem was resolved. Do you know what may have caused that issue?
Unfortunately, without knowing what
Yeah.
the baseline labs were or what the labs were after, it's kind of difficult for me to advise or give any kind of good opinion about it.
Right. If TSH level is low, should thyroid medication be increased or decreased?
Very good. So TSH is the opposite of what we think. If your TSH is low, it means there's excessive amount of thyroid hormone, which means your thyroid hormone should be decreased. If your TSH is high, that means that your thyroid hormone in the body is low and your thyroid hormone dose should be increased.
Okay. Can you have symptoms, but with normal levels, like TSH levels, and free T4, but low T3?
Can you say that one more time?
Can you have symptoms, but with normal levels, and free T4, but low T3?
Okay, so traditionally in general medicine, the kind that I practice, which is very traditional medicine, non-functional, non-holistic, T3 is reserved for very specific scenarios like Graves' disease, etc. So we would do a T4. If your T4 is normal and the TSH is normal, the symptoms are there, I would start searching for other causes. Part of the reason I would start searching for other causes is because there's so many things that overlap with many of the symptoms of an underactive or overactive thyroid. For instance, lupus, multiple things that can overlap with these things. So I think if the lab work for thyroid looks and is within the normal reference range, I would search for other causes for the symptoms the individual is feeling.
Okay. In older women, does the thyroid affect hair loss?
If you take excessive amount of thyroid hormone, the answer is you will have a more rapid or hypermetabolic state, and you would have more rapid hair loss. If you have an underactive thyroid, you would have dry, brittle hair, and you can have some hair loss. But if the thyroid function is within the normal range, it should not affect either one of those. So it's very important to keep the thyroid levels in the normal range.
Okay. If I'm on PTU and my sleep hasn't increased and I still wake up with night sweats, but my numbers are in the normal range, is there something else I can do?
So it also depends on the individual and their age. So if the thyroid labs are well maintained on PTU, that means that the overactive thyroid condition is treated appropriately. But it sounds like this individual is still symptomatic. Again, it doesn't mean that it's always the thyroid. We should think about something else. Is the patient perimenopausal? Are they going through the change? Is hot flashes a factor now and we're getting night sweats? So there are other evaluations that I would undertake in a patient with normal thyroid function on PTU.
Okay. Since you should not eat within 30 minutes of taking levothyroxine, I'm probably saying that wrong, but I think you know what I mean.
Levothyroxine.
Yes. Does this include not drinking black coffee until that time has passed?
Okay, so the answer is to be a purist, we tell our patients not to eat or drink anything for 30 minutes. Now, that's very easy for an adult endocrinologist. For a pediatric endocrinologist, mom is not going to do that. She's got to like give the pill to the kid, feed the kid, and put the kid on the bus. It's not going to work. So the pediatric endocrinologists tell them, always have the exact same thing in the morning if you don't want to wait the time. That way we could dose you for the interference. So if you're always going to have black coffee, which shouldn't have anything that much would interfere, but if you decide to use cream or something, always have that coffee. And then your levels will always be dosed for the fact that there is black coffee with cream or something like that. So ideally, you should wait 30 minutes, but if you don't and your levels look good, that means that you have been adjusted. That dose may be a little bit higher for you because it's compensating for a little bit of interference.
All right. And then this one too, we might be too specific, but we'll give it a shot. So this individual has hypothyroidism and has trouble losing weight. 13 years ago, the individual had radioactive pills. So shouldn't they be seeing an endocrinologist?
If the person, it sounds like this individual had radioactive iodine and developed what we call post-ablative hypothyroidism. That is, they developed an underactive thyroid after treatment with radioactive iodine. Then the thyroid, we would want to know that the thyroid levels are normal in the bloodstream. Because if the thyroid levels are normal in the bloodstream, and the primary physician has noted that it's within normal reference, it may not be the thyroid that is the cause of the weight gain. So it all depends. If the thyroid levels are not normal, then by all means see an endocrinologist. But if the levels have been determined by the internist or family practitioner to be normal, then we need to look elsewhere as to why there's all of a sudden weight gain.
All right. Well, that's the last question we've got currently. So if we don't have any additional questions, I think we can wrap up. I appreciate Dr. Levy and Dr. Tam taking the time to chat with everybody today.
Thank you so much, Jeff. I really enjoyed myself. Thank you, Dr. Tam. And we're going to do this again next year. Our big hope is that we'll physically be doing it. And I'll leave it up to Jeff. We're going to do it in Detroit or our usual West Bloomfield area that we were using.
Hopefully we can. We certainly look forward to getting back to in-person events. We did get one more question here if you still have a few minutes. Is there any correlation between thyroid disease and joint pain?
Yes, absolutely. There is a correlation between thyroid disease and joint pain in what respect? Thyroid disorder and underactive thyroid is an autoimmune disorder. Because it is an autoimmune disorder, they are predisposed to other autoimmune disorders like rheumatoid arthritis, lupus, etc., which are associated with joint pain. If my autoimmune patient is telling me they're having joint pain, I think it is, and they are getting swelling in their joints or any kind of joint changes that I think a rheumatologist should see them, it may be reasonable. Now, another reason thyroid hormone can cause joint pain is if your thyroid is not treated properly. So if your thyroid is completely underactive, people can have all kinds of symptoms due to improper treatment. So the first thing is to properly treat the thyroid. And if there is joint pain, despite the fact that the thyroid has been treated, we would have to consider whether rheumatology needs to get involved.
Okay. Can sinus issues irritate the nodules?
Sinus issues can cause postnasal drip, which I would tell Dr. Tam to talk about, but in per se, it's not doing anything to the nodules.
Okay. All right, that appears to be our last question, so I'm going to go ahead and wrap this up. And thanks again. As a reminder, everybody, we will send you out a link to this presentation via email, so you'll receive that and keep it for your records. All right.
Thank you, everybody.
Thanks, everyone.
Thank you.